These two side-by-side graphs illustrate a profound biological contradiction. On the left, as physical activity increases, all-cause mortality drops rapidly, following a well-documented reverse J-shaped curve. On the right, at the exact same extreme percentiles of physical activity, coronary artery calcium, or CAC, scores sharply spike. Epidemiological data from the Heinz-Nixdorf recall and Mark I cohorts map this extreme right tail directly to male masters athletes. These individuals accumulate decades of systematic endurance training, and their scans reveal high volumes of calcified, mixed morphology, and non-calcified coronary plaques. This highly reproducible clinical signal is known as the athlete calcification paradox. Traditional cardiovascular risk models consistently fail to predict this phenomenon. Calculators like the Framingham risk score weigh chronological age, circulating lipids, and resting blood pressure to estimate a patient's 10-year event risk. They account for metabolic dysfunction, but they have no mechanism to calculate localized mechanical vascular damage. This 2x2 matrix highlights that algorithmic blind spot using the Heinz-Nixdorf cohort data. Marathon runners presenting with a highly favorable low 7% Framingham risk score were found to harbor median CAC scores matching those of high-risk, completely sedentary populations. The clinical tension is clear. Individuals with pristine metabolic profiles, high cardiorespiratory fitness, and ideal body compositions, who simultaneously harbor severe, advanced structural coronary pathology. To resolve this paradox, we have to look past total plaque volume. We must examine localized hemodynamic mechanisms that uncouple anatomical atherosclerosis from cardiovascular mortality. Global guidelines recommend 150 to 300 minutes per week of moderate physical activity. This is the baseline longevity zone, providing the sharpest absolute reduction in all-cause mortality. As volume scales up past 3,000 MET minutes per week, the mortality curve hits a strict plateau. At this extreme threshold, the structural risks to the cardiac muscle rise significantly, but the individual gains no incremental survival dividend over moderate exercisers. This hazard ratio matrix compares the expected mortality penalty of structural disease. In a sedentary clinical population, possessing a CAC score over 100 Agatston units roughly doubles the relative risk of dying from cardiovascular disease. The Cooper Center longitudinal study tested this penalty against extreme exercisers. Active men generating over 3,000 MET minutes per week who possessed high CAC scores showed no significant all-cause mortality increase compared to peers with zero CAC. Their hazard ratio sat at an insulated 0.77. Notably, this paradox heavily skews toward male athletes. A 2024 analysis in the journal Circulation confirmed that in female masters athletes, coronary plaque burden is driven exclusively by traditional clinical factors, such as advancing age, elevated systolic blood pressure, and lipid profiles. The mechanical stress of exercise duration and intensity showed no statistical association with accelerated calcification in women. For men pushing extreme volumes, sustained supraphysiological physical activity creates a protective clinical buffer. It neutralizes the mortality risk of objectively measured structural coronary disease. Historically, cardiologists reconciled this buffer through the healing hypothesis. This model assumed that exercise-induced plaques in athletes were exclusively dense, calcified, and therefore structurally stable against rupture. The multi-center Master at Heart study deployed contrast-enhanced computed tomography angiography to measure the absolute prevalence of all plaque subtypes across different training histories. The resulting data broke the historical consensus. This table compares sedentary controls, late-onset athletes, and lifelong endurance athletes. It reveals a clear dose-response relationship. Lifelong athletes possess higher absolute volumes of purely calcified plaques, but also possess significantly higher volumes of high-risk non-calcified and mixed morphology lesions. The anatomical placement of these lesions adds to the severity of the findings. The Master at Heart cohort showed a distinct concentration of plaques within the proximal segments of the epicardial tree. Proximal blockages, particularly in the left anterior descending, or LAD, artery, carry high inherent ischemic danger. A thrombotic occlusion at this specific anatomical juncture jeopardizes massive territories of distal myocardium. If lifelong endurance athletes harbor significant volumes of high-risk, proximally located non-calcified plaques, we have to determine why they do not suffer rampant, catastrophic plaque ruptures during competition. Longitudinal tracking in the Mark II cohort isolated the specific trigger for accelerated calcification. Total cumulative training volume did not drive plaque expansion. Plaque expansion scaled specifically with the proportion of training time spent at very vigorous intensities, exceeding 9 nets. Near maximal exertion demands a massive, sustained surge in coronary blood flow, often escalating absolute cardiac output to 5 or 6 times its normal resting volume. Under this extreme load, macroscopic fluid dynamics shift. Blood flow becomes highly turbulent at the bifurcations and proximal curvatures of the epicardial tree. This sustained pulsatile crashing generates intense local wall shear stress, continuously inflicting recurrent microvascular frictional injury directly onto the endothelial lining. Simultaneously, the exertion triggers a systemic hormonal cascade. Acute, transient spikes in parathyroid hormone forcefully mobilize serum calcium straight from the body's bone reserves. Operating at the sites of endothelial trauma, this newly mobilized calcium is drawn directly into the arterial intima as an emergency biological repair process. This mechanically driven osteogenic repair pathway operates entirely separate from the lipid-driven, metabolically pathological atherogenesis found in sedentary patients. This cross-section demonstrates the resulting neo-media hypothesis. To survive the recurrent trauma, vascular smooth muscle cells undergo a phenotypic transformation, migrating up to construct an exceptionally dense fibrous cap over the underlying lipid core. This hypertrophied cap acts as biological armor. It physically separates the necrotic core from the turbulent bloodstream, shielding the vulnerable plaque against extreme hemodynamic shear forces. The master at heart data validates this mechanical stabilization. Despite having higher absolute total plaque volumes, lifelong athletes showed an odds ratio of 0.11 for possessing plaques with multiple high-risk vulnerability features compared to controls. Athlete atherosclerosis is a highly localized mechanobiological adaptation designed to physically reinforce the vessel wall against the recurrent trauma of extreme cardiac output. Microscopic plaque stabilization is only half the survival equation. To understand the lack of mortality, we also have to account for the macroscopic structural remodeling of the entire epicardial network. Decades of high-volume endurance training induce profound arterial dilation. The baseline resting luminal diameter of the athlete's coronary arteries expands outward. Looking at these two cross-sections, the mathematical advantage becomes clear. A plaque causing a 50% mathematical stenosis in a massively dilated athlete's artery leaves a much larger absolute path for blood flow than an identical 50% stenosis in a narrow, sedentary artery. Athletes further protect their myocardium by developing supranormal coronary flow reserves and dense, redundant networks of collateral macrocirculation capable of bypassing major epicardial blockages. This biological protection is substantial, but it is not absolute. Roughly 14% of elite cohorts display late gadolinium enhancement on cardiac MRIs, indicating subclinical myocardial scarring, likely driven by severe, localized demand ischemia. This flowchart diagrams the 2025 American Heart Association and American College of Cardiology clinical guidelines. Acknowledging the paradox, modern protocols explicitly abandon risk-averse, automatic disqualifications based solely on a high CAC score. Instead, they mandate advanced CCTA imaging, strict exercise stress testing, and shared decision-making. If stress testing officially clears the athlete of high-risk ischemia and arrhythmias, the guidelines support a protocol of permissive continuation, allowing the athlete to actively continue extreme competition. However, high fitness does not excuse the patient from pharmacology. The guidelines require aggressive secondary medical prevention, mandating the initiation of statin therapies and rigorous blood pressure control to blunt further disease progression. By combining advanced imaging with evidence-based medical management, clinicians can safely support the aging athlete. The data confirms that the global mortality benefits of sustained high-level exercise overpower the localized anatomical presence of structural coronary disease.